Good morning, everyone. Welcome to the Neurosurgery Grand Rounds. We have an excellent guest speaker today, Dr. Matthew DeCamp, who's going to give us a lecture on something that I think is very important to learn about these days, which is artificial intelligence. It's becoming nearly ubiquitous and rapidly involving every aspect of care, as well as other aspects of our lives. And I think we really need to kind of make sure as we adopt new technologies that we're not overutilizing them or carefully utilizing them. So hopefully we'll learn quite a bit from Dr. DeCamp today. And I thank you very much for taking the time and getting up a little bit early to give us this talk. So thank you very much.
Sure thing. I really appreciate the opportunity and totally agree with you. It's affecting so much of care already. I'm an outpatient general internist, and I'm certainly already using AI in a number of ways, as you mentioned, throughout the rest of our life as well. So I'm going to try to go quickly through some slides, and perhaps if there's time at the end, we can have some questions and answers. I could probably talk about this for 1 or 2 hours, frankly, but we'll do the best we can to at least cover some of the big picture high points when it comes to ethics and AI. I don't have any conflicts of interest to disclose. I do have some research funding that I'll reference a couple times in the presentation. And when I talk about products, it's just for illustration, not any sort of endorsement. Those are our learning objectives for today. Many people think that AI really is the future of medicine, and what does that look like? Well, this is an example of using generative AI to create a picture, and I asked AI to show me the future of medicine. And here it is. Very, on the one hand, impressive picture created by only typing in 4 words, the future of medicine, but also a little disturbing, I would say. You notice in the upper left, the future of medicine is misspelled. I went back and checked, and I actually had spelled the future of medicine correctly, and yet the AI misspelled it. I'm not sure what those organs are in the background. You may know better than me. I don't know why this person was portrayed as the future of medicine. I'm not sure what to make of the hand gesture either, and if you look closely, the hand has 6 fingers. So on the one hand, an astounding example of what AI can do, and on the other hand, errors that we see present in the image. This is a diagram from just a few years ago showing the number of AI-based applications already in use in medicine. And if you look along the right side of this slide, you'll see really it's the full range of medical specialties from cardiology, radiology, of course, neurology, oncology. FDA has authorized more than 900 AI-based applications for use in care. Not approved, not assessed in the same way as drugs or devices per se, but authorized these largely under the device pathway. These are some more specific examples of AI in healthcare that again reflect quite broad range of uses, from predictive analytics like AI-based mortality prediction, that's an area of research of my own, image interpretation, diabetic retinopathy screening, or Google's Derm Assist, which uses a picture from a mobile phone to assess the risk of melanoma in a mole photograph. Caregiver and other robots are being used, especially more so in Japan. Robert and Pepper are the names of robots like this. We have patient-facing chatbots like our own in the health system, but also Wobot, a chatbot that's used for mental health therapy, whose developers tout that it develops human-like bonds in only 3 to 5 days. And lastly, some of you may have heard, and maybe you're already using, because we're already using this in my health system, using LLMs, large language models, or generative AI for things like ambient note-taking or responding to patient portal messages. When I get a message into my in-basket, the first response, a smart reply, is suggested to me that's generated by artificial intelligence. So lots of uses in healthcare. In neurology, neuroradiology, neurosurgery, also seeing plenty of examples of use. In the upper left, These are MRI images, of course, but the AI-based program behind this is used to detect or differentiate pseudoprogression on an MRI from true progression of glioblastoma. The lower right, using AI for the interpretation of EEGs, having the machine help us interpret the presence of seizure activity. Those are more in that image interpretation realm. Predictive modeling also, I found this example regarding predicting response to spinal deformity surgery, an example of using large data, big data from electronic health records, combining them from registries that currently exist and using machine learning to detect who would benefit, who's likely to benefit from a procedure like this one. And then you may have already heard of this too, AI-assisted surgery, sometimes described as like having a senior surgeon looking over your shoulder, basically taking many, many videos of procedures, combining them over time, asking the AI to help interpret what happens during those surgeries, and then creating an image on the left screen on this slide where those AI-assisted images are meant to help guide the surgical procedure along the way, alongside the real images that you see on the right. And if you look closely at this left part of the slide, you can see this is an article from just really a few days ago regarding this particular technology at Oxford. So lots of examples already in healthcare. We also have lots of ethics guidance, I should say. We have plenty of ethics principles that should govern how we use and implement AI. We've had them for a while, moving left to right. The World Health Organization has put forward principles. The White House, the Canadians have put forward principles. The European Union recently passed something called the AI Act, which emphasizes a number of these ethics principles that you see down below. And if we spend a lot of time on this slide, we would see lots of overlap around issues of transparency, choice, accountability, privacy, and so on. The one issue I want to focus most on today is the issue of fairness or bias or equity in AI, and how do we make sure that AI is being used in a fair manner? Although, as you'll see, this concept of bias turns out to affect every other ethics issue we might have for AI in healthcare. And so I see bias as a lens, a way that we can see other ethics problems more clearly once we understand bias in artificial intelligence. What is AI? Well, as you probably are all using AI, I think it's still helpful to make sure we're on the same page for what these technologies are. They're not new. AI has been around, has had multiple boom bust cycles over the past decades, really. In the 1970s, there was a program called Mycin. I was fortunate enough in my own clinic to work with an RN who actually, in a prior part of his professional career, had helped develop Mycin. And Mycin was a program to help clinicians diagnose and then treat serious bacterial infections. Now, this was rudimentary AI. This was rule-based. Think of it like a flow chart that's put into a computer to aid decision-making. Most of us now are much more excited about machine learning and these more advanced AI techniques. And if you've used recommender systems like Amazon or Netflix, then you've used machine learning. And by the way, Netflix touts that 80% of choices on Netflix are influenced by the recommender system. So a clear evidence of AI affecting our choices for better or maybe for worse. When it comes to deep learning, a subset of machine learning, if you've used translation, as we'll talk about chatbots, or if you've heard of facial recognition software, this is really deep learning. And then, of course, purposely in the black circle, generative AI, ChatGPT, Bard, that image I showed you earlier, that image generated, those come from generative AI as a subset of artificial intelligence. How do these things work? I'll go through image interpretation, AI predictive analytics, and generative AI to give you a quick sense for how these technologies work. So how does AI learn to see images? Well, let's suppose we had to solve one of the most intractable problems in medicine. That is, how do we sort pictures of blueberry muffins from pictures of chihuahuas? Well, we would need an artificial intelligence image analyzer, and we would show it these pictures. We would say, there's a blueberry muffin. There's a chihuahua. And we keep showing it pictures. We have a gold standard supervisor. It could be you, it could be me, who looks over top of the machine and assesses and verifies that it's correct or it's accurate. We do need that gold standard. Then we start showing pictures. There's a muffin. There's a chihuahua. Chihuahua. Muffin. Chihuahua. Oops, it gets it wrong. And those things do look remarkably alike, I would say, but eventually it gets it wrong. And that's the point of the supervisor, to say and correct that particular interpretation. Now, as you can imagine, once we've created this analyzer, if we show it a picture of a St. Bernard, we don't know what will happen. Maybe it characterizes it as a blueberry muffin. It's hard to predict because this particular analyzer has not seen a picture like that one. So an important point about image interpretation that we'll follow through on a bit later. How about predictive analytics, predicting the future? Well, many of us are familiar with the idea that if you're seeing a clinician, they can use your height, your weight, your blood pressure, and so on to predict future disease risk like heart attack, stroke, or cancer. Well, with artificial intelligence, we can now combine billions of those data points, millions of electronic health records, and using the power of AI, we follow patients over time. We see who gets heart attacks or cancers. And the power of AI is that we can identify new predictive factors, and we hope make better predictions through the use of big data and through the use of greater computing power. Lastly, generative AI. How do we create that picture at the beginning that I showed you? As the chair of our Department of Biomedical Informatics says, generative AI is analogized as a fill in the blank. And we all know what to say next. We all know that blank comes next. Casey also says that generative AI is like the annoying friend at the party who insists on completing your own sentences before you do because it's predicting what comes next in the sentence. And how does it do that? Well, it's been trained. It's been trained on textual information from the internet, from freely accessible books and articles, with a little bit of that human oversight, some of that supervision, to then hone in on a prediction of what should come next in a particular sentence or what parts of an image should be put together. Now, that's grossly oversimplified, but that statistical notion of predicting what comes next is really important when we think about generative AI. The common thread between those three distinct uses is that AI is only as good as those data that are used. Keep that in mind. The data really matter as far as how well these technologies are going to perform. Now I want to move to this topic of bias in AI and spend some time on it to make sure we are all in the same understanding of where bias comes from. In our own research, we're looking at AI-based predictions, AI-based prognosis, a proverbial crystal ball that claims to predict a patient's death, sometimes with shocking accuracy, 6 months, 1 year, 2 years. Some studies say 4 years in advance of that patient's death. In our R01 project, we want to understand what patients, families, and clinicians think about this in general. And you can imagine this technology raises a host of ethics issues around choice, transparency, fairness, and so on. And I want to focus on this bias aspect. We look closely at the publications that support the use of predictive tools like this one. We'll often read this: the algorithm has shown high accuracy, but the overall accuracy is reduced in certain subgroups, such as racial and ethnic minorities and less educated individuals. You'll see sentences like this often buried in the limitation sections of papers. Biases aren't just in these predictive tools, though. We see biases in image interpretation as well. This is a technology that's used to help read chest radiographs. When you look closely at the performance, here's what you find. It performs less well in patients who are female, of Black race, of Hispanic ethnicity, on Medicaid, or who experience intersectional disadvantage from the standpoint of justice, meaning they have more than one of the above. So the technology seems to perform less well in some populations versus others. And lastly, A visual example of bias in generative AI. This is another picture that was generated by AI software. Give you a minute to look at it. This is the prompt of the AI. Traditional African healer is helping poor and sick white children.
Can you see this?
I think this is pretty shocking to see that an image could be generated like this one, almost as if the AI can't conceive of something other than a picture like this based on the training data, the images it's seen before. So a visual illustration of lurking biases even in generative AI. Now, from a philosophical perspective, bias is any systematic unfair weighting of a person, thing, or an idea. And we have to keep this broad notion of bias comes up when we use AI. Where does it come from? Bias is a three-part bias sets. There's the potential for bias processing or analysis, and then biased output or use of the technology. Now, the usual focus is here on biased data sets, and it's important that we cover that topic, but I actually think the problem is far deeper than that when it comes to the analyses and output or implementation. No doubt we have biased data. And this upper left figure do nothing other than follow the yellow piece of pie. That shows the overrepresentation of European and North American ancestry in our cell lines, our biobanks, and our genomic data sets, a bias that will affect how AI performs. We all know that there are historical and today still inequities in clinical trial participation, particularly among native populations in our country. Again, if clinical trial data are not representative of the broader population, that's why when we put these into practice in AI, we will see differential performance by group. There are also odd forms of bias in AI algorithms. This is a figure I created from a JAMA publication now a year or two ago. And this publication suggested that most AI-based algorithms in healthcare are built using data from only 3 states, New York, Massachusetts, and California. Again, an interesting form of biases in our data that in a state like Colorado, we really care a lot about. And when I talk about bias, I mean bias in all its forms. So I'm going to point out a couple additional types of bias that can affect data that are used in AI. The upper right, positive results bias. We know there's a bias toward publishing positive results in the medical literature. This means that when that same literature is used, as I showed you, for AI, it's going to reflect positive result bias. There's also historical bias. All of these models have what's called a knowledge cutoff date, meaning a point at which they've not seen new data. So if your topic is new, if your area of research is novel, it's innovative research, it may not be reflected in the model's output because of that knowledge cutoff date, creating a little bit of a bias toward history. And I'll give you a practical example of this. In our large language model that we respond with messages to patients, a patient asked about the RSV vaccine. Model's output said there's no such thing as an RSV vaccine. And the reason was it had been approved post that knowledge cutoff date. So a clear potential for inaccuracy, for harm in the model because of the date upon which it was trained. Lastly, going back to this data source bias, you remember what I said about AI training models earlier. I made a quick comment that the training data come from publicly available data. Now, there's a lot of controversy about this as to what ChatGPT has really used. And people would say that the models have been trained on publicly available open access data. And this is like a sieve, because we all know that not all information, not all data are simply in open access public databases. When I talk to students, I tell them if you're using generative AI, think of it like completing your assignment, completing your research paper using only the information you can find through publicly available sources or on the internet, meaning that you can't use those institutional subscriptions or journal articles that come from behind paywalls because they're technically not in the public data that are used to train AI. So another way that bias can come in to AI applications and their output because of the data that are used to train it. Problem 2 is bias processing. We'll shift now to that analysis portion of the 3-part problem. This is a publication that got a lot of attention a few years ago, still gets attention today, because it was the identification of racial bias in an algorithm that was used for care management, to manage the health of populations. There were racial biases found in the way this algorithm directed care management resources. Why? Look at this portion of the abstract. Bias occurs because the algorithm uses health costs as a proxy for health need. Less money is spent on Black patients who have the same level of need, and the algorithm thus falsely concludes that Black patients so not a instead a bias in the analytics. Who chose that variable, who chose to use cost as a proxy for need, or really importantly, it could have come about because of algorithmic performance, especially if the algorithm is unsupervised. If you ask an algorithm to get to a certain task, a certain outcome, that algorithm can be path independent, meaning it doesn't care how it gets there, as long as it achieves that objective. And if so, it might use biases like this one, make mistakes like this one did in choosing a particular variable, even though it's not the correct one. So a bias that occurs because of how we analyze data. Problem 3, biases in the output or use. I frame this as the question as what happens when even so-called fair AI enters our unfair world? With colleagues, we wonder, what if we even had a perfect AI model? The data are perfect, the analyses are perfect. What happens when this comes into practice? Well, drawing on the concept of latent errors, that is system errors that we say are waiting to happen in a medical or health system, we wonder about latent biases, that is biases in the system that are waiting to happen once the technology is in use. This could be patients who distrust health systems and choose against technology that could otherwise benefit them. It could be clinicians who decide to use AI for this patient, but not that patient, creating a bias in the way the AI is used. And keep in mind, to the extent that AI is adaptive and learns over time, it learns from choices in the real world to then improve itself. Choices like these in the real world will affect performance over time, potentially creating feedback loops, either positive or negative, that will reinforce or perhaps mitigate biases in performance over time. There are strategies that are out there for addressing biases in AI. I think it's important to keep these in mind. We can engage communities as partners, data to our clinical trials, to our registries, and so on. There's evidence that if we create diverse teams, they may be less likely to make those biased assumptions I showed you just a bit earlier. When it comes to biased outputs and use, as you'll quickly see from the prior slide, we still have to reckon with those underlying social and structural inequities that affect our healthcare system today. So AI becoming yet another lens to see some of these more foundational issues of access, fairness, equity, and so on. But I want to point something out about these 3 solutions. Strictly speaking, they're not just about the data, even though the focus is often on the data sets. And that's why I like to say that bias in AI is more actually a social problem. Make a comment about where the solution is not when it comes to fairness in AI. There's a lot of attention now toward creating nutrition labels, so to speak, for artificial intelligence algorithms. And you might think, well, why don't we just certify algorithms as fair so that we know them at the point of care, whether it's fair or not? We don't have to engage in a complex ethics calculus. Instead, we can rely on this label. Well, that's a great idea for a lot of artificial intelligence. I'm not sure it's a great idea for fairness, and here's why. Number one, philosophically, we haven't agreed about fairness for hundreds, if not thousands, of years what really fairness is. And importantly, we can't meet all the dimensions of statistical fairness simultaneously. If you looked at this algorithm's performance and looked only at accuracy and precision, you might say, this algorithm is pretty fair. But if you move to positive prediction, you see that the performance comes about. So even in this simplified example, what it shows is there are real-world conditions where prevalence of diseases are different. In these real-world conditions, it is impossible to meet all the statistical notions of fairness simultaneously. And this is known as the impossibility theorem of fairness metrics for AI. Key implication of this, as has been reflected in recent frameworks to address algorithmic bias in healthcare, is this guiding principle. Instead of focusing on a fair label, our ethics obligation is to try to identify the algorithmic fairness issues and make those trade-offs transparent, make it clear what we're trading off when it comes to the performance of the particular model. Now, to do that, we need fairness metrics, and this is sort of, I think, the next wave of what's going to happen for bias and fairness in AI is the creation of fairness metrics that help us assess models. Some are out there, but there's a lot more work that needs to be done. I just want to point out three key ethical differences that can come up for fairness metrics. This is a publication, it's from the Google group. And in this publication, they propose a particular fairness metric. I'll say which one in a moment. But in getting there, they suggest that fairness metrics come in three different general types from the standpoint of ethics. And I'm going to overlay ethics concepts on top. On the far left, this reflects the idea that an algorithm should do no harm. That is, so long as no one is harmed because of the use of the algorithm. This is a different approach to fairness than the middle figure, which suggests that so long as everyone benefits the same, just as a rising tide lifts all boats, that means the model is fair. A third fairness metric, and this is the one the Google group has put forward and tested, specifically in dermatology applications, so a lot more work to be done for what they call their HEAL metric. The HEAL metric is meant to actually assess narrowing the gap in healthcare disparities. That is, from the standpoint of fairness, it's not just that no one is harmed. It's not just that the rising tide lifts all boats. We actually want to see mitigation, reduction in healthcare disparities because of the introduction of AI-based algorithms. By the way, we need all of this really soon. These fairness assessments, fairness trade-offs, and these metrics, because if you followed federal regulations back in April, federal regulations proposed in 1 year, so half a year or so from now, attaching liability to health systems who develop or deploy artificial intelligence-based algorithms, should those algorithms be shown to be discriminatory. So now this is a matter of critical concern to health systems. The regulations define this broadly to include support tools, so not just AI. They operate along those traditional lines of race, color, origin, sex, age, disability, and so on. And then really importantly, the emphasis is on whether the covered entity, whether the health system made, quote, reasonable efforts, quote, to identify and manage biases in algorithms. So if your health system is like mine, we are actively trying to figure out what it means to make reasonable efforts to identify and manage biases in algorithms, creating a lot of attention toward AI governance structures. And in fact, in our own state of Colorado, there's a state law that's encouraging us to do this as well, again, over the past year, trying to figure out what counts as practical steps to meet this likely new requirement. I want to shift to a different ethics issue now. We've talked about bias. And I want to shift now to the question of transparency, another hot topic, I would say, in AI. And to do that, I'm going to introduce you to Livy. Livy is our UC Health Systems virtual assistant, patient-facing chatbot. You can access Livy by mobile device, and Livy is linked to your personal electronic health record. This panel just shows a conversation I had with Livy around advanced care planning. You can imagine the potential of patient-facing chatbots like this. When linked to the EHR, they could offload administrative tasks like scheduling, test result return, and so on. They could deliver personalized care reminders like colon or mammograms. At the end of my conversation with Livy, oh, Matt, I happen to notice you're overdue for your colonoscopy. Would you like for me to get that scheduled for you? That's made possible because Livy is linked to your personal EHR. And again, in a state like Colorado that cares about rural care, access to care, chatbots like Livy could break down geographic barriers to care, enabling people to access care from places where they otherwise might not. But in our research, lived more than 600 patient users, and we asked them, when you were interacting with Livy, what did you think Livy was? And if you see the pie chart, you quickly recognize that about 1 in 3 didn't know. And some, a small percentage, 6%, even thought Livy was a real person typing back to them on the screen. When we look closer at these data, again, from that standpoint of bias and systematic disadvantage, we found that correctly identifying Livy correlated with race or and education status, but not age or gender. I'd say that the age point was a little bit surprising to us. I think there are ageist assumptions about technology and digital literacy. We found that not to be the case, but we did find that there was differential impact of the technology based on race or ethnicity in terms of how Livy was perceived. This raises questions around we need to be transparent, how much to be transparent about the use of AI. You see at the bottom of this slide, the American Medical Association in November 2023 put out principles for the augmented intelligence development, deployment, and use. And one of those that they focus upon is transparency. When it comes to transparency, they recommend a risk-based approach where the level of scrutiny, validation, or oversight is proportionate to the overall or disparate harm and consequence. Sense. Not every application, it really depends on risk. They go on to say that use of AI-enabled technologies by hospitals, health systems, practices, or other entities should be clearly disclosed to patients, much as Livy introduced herself, if I can say herself, as being a virtual assistant in our health system. And then lastly, AMA says that when AI is used in a manner which directly impacts patient care, that use of AI should be documented in the medical record. It's at this point in our stepwise process where I think many of us scratch our heads. Questions like, why have to do this for AI compared to other decisions we make? I don't document my use of journals, colleagues, or perhaps up to date in the electronic health record when it's impacted my medical decision. Why should we expect it to disclose and document any use of AI in the medical record? So a question as to whether transparency perhaps in this ethics guideline has gone a bit too far. Along with those surveys of patient users of Livy, we've interviewed people and gotten their experience of that patient-facing chatbot in some depth. And one of the things we've observed is another potential emergent bias, differential impact of the technology. How did we get there? Well, sometimes we heard comments like this. Because I'm a person of color, thinking a little bit of the basic hair design, because again, I think it just gives it a little bit more of a connection to minorities in our health. This research participant, patient user, clearly reflecting on why Livy looks the way Livy does. Why do we have Livy appear like that. In fact, this participant is onto something. In the technology world, there's a phenomenon known as mirroring. And mirroring is the idea that if you mirror the user's appearance, you might make that chatbot more effective at behavior change. Those things like colonoscopy reminders may be more effective if the chatbot looks or talks or acts a little bit like you. This raises a really important ethics question. Can we design chatbots to achieve the benefits of mirroring, say based on gender, without crossing some ethics line into manipulation? Where do we draw the line between nudging people toward positive behavior change or feeling like using some of those characteristics like race or gender and so on verges into manipulation of choices rather than informing choice? Last topic. I'm going to spend some time talking about how bias intersects the role of explainability or explanation in artificial intelligence. You might wonder, when it comes to interpretation of AI, what does it make the interpretation between Chihuahua and Blueberry Muffin? Or in this case, how does it interpret this clear pneumonia in the right lower lobe? Well, it turns out you can ask AI the question, what are you looking at? And it can generate a heat map like this one, where higher numbers reflect greater influence over the image interpretation. And if you look at this slide, this image, you'll see quickly that the higher numbers are at the bottom. That's odd. Clinicians would identify the right lower lobe pneumonia in a different place than the AI is saying influenced its interpretation of the image. Why might this happen? Well, in practice, we know that it might happen because buried in the lower part of the image could be clues. Could be something like a location or the site of where the chest x-ray was taken. And if the chest x-ray is taken in an intensive care unit, and that location is indicated in the lower part of the image, well, that raises the pretest probability of pneumonia, and the image interpretation keys off of that. That influences the picture. But still a bit perplexing when we see things like this, asking us this fundamental AI question: how do we explain what AI is seeing? Why do we care about explainability? Why do we care or fear the idea of a black box where we can't explain how we went from data to prediction? I think many of us, again, believe that explainability is a foundational concept for informed consent. I can't engage in an informed consent discussion with a patient if I can't explain how the model came to its conclusion. Many people believe that explainability is important to trusting and using artificial intelligence in healthcare. And lastly, others believe that explainability is necessary for how we think about responsibility or liability for medical errors. I shouldn't be held responsible as a clinician for a model if it's impossible to explain the black box. How can I be responsible for its output? I like to present a word of caution about the emphasis on explainability. Again, philosophically, we've long thought that knowing how something works is a higher form of knowledge, a higher form of expertise than knowing that something works. But I do think caution is in order. Many people would say that the blackest of all black boxes actually sits on top of clinicians' heads. How a clinician came to a particular decision about a patient or about patient care. I think it's also really important to remember that clinical trials, that gold standard of evidence that we all use, are not always causal. I use the example that if you asked me today versus 5 years ago versus 15 years ago, how does a statin work to lower the risk of stroke or heart attack? My explanation has probably changed over that time. The explanation of how it works. But we've long known that they work. And that's been enough for us to make clinical decisions because we rely that it works, and we may or may not have the correct information for exactly how it works. Lastly, in the technology world, there's thought to be, in some cases, an inherent trade-off between accuracy and explainability. The more accurate models, the most accurate models we could create may in some cases be those black boxes. They may be inexplicable. And yet I would venture to say that when I'm in the room with a patient and I give them this choice, here's your choice. We can use the model that I can explain, or we can use the accurate for you. Which is it going to be about this healthcare decision? I'd venture to guess that most patients are going to choose the model that is accurate. This raises questions about the unique role of human expertise when it comes to healthcare, medical decision-making in general, and AI in particular. One of the things that's touted as being so important, and I think it is important, to safety measures and choice in healthcare AI, that human physician in the loop, as you see on the left side of this slide, the idea that so long as we keep a human clinician in the loop, we can protect ourselves against some of the problems that come about because of AI. It is important, but I do wonder at times if choice can sometimes be illusory when that human is in the loop. We know of the phenomenon of automation bias. Automation bias is the idea that humans tend to follow recommendations given by computers. Think back to what I said about Netflix at the very beginning. 80% of choices influenced by Netflix recommender system. Now that's in Netflix, and that's about movies and shows, and it may not be, it's clearly not the same as healthcare decision making, but the phenomenon is still present. So automation is more of a problem. It's problematic to continue to follow the recommendation of the computer when cognitive burden is high, when time pressures are acute, and when tasks are complex. All things that are present in contemporary healthcare, in some cases making it easier to follow the algorithm's output, affecting independence and autonomy of choice at the clinician level, reflecting a little bit back to what I was saying about patients and nudges from the chatbot. Now we're talking about influences on choice at the level of the clinician. I want to illustrate this again and show how much research we still need to try to understand this phenomenon of automation bias and the human factors that affect decision-making with AI and augmented intelligence. This is a study of AI-assisted chest X-ray reading, one of those technologies I showed you earlier. In this study, AI helped some in terms of performance and worsened others. You might ask, what predicted AI-assisted success? Which of these factors predicted that a radiologist performed better when it came to AI-assisted diagnosis? Do you think it's years of experience? Is it special training, like subspecialty training in radiology? Or is it prior use and familiarity with artificial intelligence algorithms, with knowing how AI works? You may have an idea of whether it's A, B, or C, but in fact, the correct answer is none of these. None of these turned out to be strong predictors of who was improved by the use of AI and who was worsened. Now, there is a general observation that's been made, which is that AI assistance seems to worsen our highest performing clinicians. Our highest performing diagnosticians do seem to be at the moment affected negatively by the use of AI, that top part of the bell curve. But beyond that, it turns out to be really hard to predict how people will respond to AI assistance, who needs it, who doesn't. And over time, I think we're likely to see this play out in different ways. We just need a context specific to determine which factors are present and how best to predict success. I want to close with just a quick comment because I think this area is interesting about those AI-generated responses to patients that we use in our health system, I may get a message in the patient portal like this one. Dr. DeCamp, hope all is, and by the way, this is a real example shared with permission. Hope all is well. I received a message yesterday to schedule a fluoroscopy. I think this may have been from my swallowing issues. Since then, I think things have definitely been fine. So if it's okay with you, I won't follow through with the test. I continue to have that persistent dry cough. Should I do anything about it? Let me know your thoughts. Luckily, I've been feeling great. Very, I think, representative example of the types of messages I get as an internist from the patient portal. Here's what the LLM did. Thank you for your message. It's good to hear that your swallowing issues have improved. If you're not experiencing any problems, it's reasonable to postpone the fluoroscopy. However, if symptoms return, we should reconsider. It's doing a pretty good job here, I would say. And then look, it actually has a carriage return and starts a new paragraph for the next symptom. Regarding your persistent dry cough, it's important to monitor this. If it continues or worsens, we should investigate further. I'm glad to hear you're feeling well overall and have rescheduled your colonoscopy. Colonoscopy. We didn't see anything about a colonoscopy in this particular patient portal message. An example of an AI-based hallucination where it filled in the blank, but it did so wrongly and references a colonoscopy. So again, it did very well until it didn't. Then you'll notice something here at the bottom, a nod towards transparency. Our health system very intentionally includes this disclaimer at the bottom of these messages. The text was automatically generated, then edited, in this case, not edited by myself. A couple comments about even that disclaimer. We didn't say it was AI. We didn't say it was a computer. Did we do enough for transparency, for those ethics questions of how much to disclose, who to disclose it, how to disclose? Did we do enough? I think an open question, perhaps, for discussion. I want to note something else about these smart replies. They don't just sit between us. They also can have the potential to change how we view each other. This is a study from outside healthcare about AI-based smart replies. Take a moment on this. Perceived use caused the recipient, who could be a patient, to review the sender, who could be a physician, more negatively. Perceived use causes a more negative assessment of the other, but actual use caused the recipient, who could be a patient, to review the sender, who could be a physician, more positively. So if you don't know it's being used, you actually like it, creating foundational tension in ethics, and the idea that AI, in this case, can improve relationships, but only if patients don't know it. Tensions between transparency and healing relationships. I'm going to close with just this quote that I sound like a critic of technology, perhaps, but I'm excited by some of these, especially those LLM-generated responses, ambient note-taking. This is a quote about a technology. The quote is from 1821. It's physicians criticizing a new technology in healthcare. That it will ever come into general use, I am extremely doubtful, because its beneficial application requires much time and gives a good deal of trouble, both to the patient and the practitioner, and because its whole hue and character is foreign and opposed to all our habits and associations. It must be confessed that there is something even ludicrous about this technology. Some of you may know that this was written about the stethoscope, technology that, of course, we eventually adopted, and some would say now we don't use as much as we used to, but we clearly adopted it for a time once we were able to work out some of the difficulties and challenges that come with any new technology in healthcare. So we have a great team at our center that works across these research projects. We have partners at UC Health that help as well. I want to acknowledge their contributions, and I'm very happy for the next 6-7 minutes. If there are questions or comments, happy to have a discussion as well. So thanks so much for your time.
Thanks so much for presenting this. This was very interesting. Some have suggested that for AI safety, that a prioritization of lower risk applications over higher risk applications would enable AI to be implemented safely. So for example, the Netflix recommendation engine relatively low risk. And then, for example, bail decisions would be very, very high risk. Do you think the FDA should have, kind of a sliding scale for these applications and focus on risk mitigation, or do you think that it should have a relatively uniform standard?
Great question. In fact, the guidance that FDA has put out does take that sort of a risk-based approach. I believe they use 3 categories of risk in the framework that they use to assess AI-based applications as devices. So this goes under the device rubric for them, and it is risk-based. So you're spot on, and I think it's the right approach, by the way. What we also see is even though FDA does that, I think really importantly, many health systems develop their own AI or decide whether to use AI themselves. And those AI governance structures within health systems also need to reflect that risk-based approach, because I think it's just such an intuitive one to start there. And then the assessment of how much transparency, how much effect on choice, how much do we care about bias? All of that will come from that initial risk assessment. So I appreciate your question. I think you're spot on. And I think the FDA knows that as well.
Any other questions? Well, thank you so much for presenting this. This one was wonderful.
Great. Thanks for the time. Hope you all have a great day.